Okay, so we're almost done, folks. This will be the last one. It won't be as long. Going on again, and again, this was updated in 2012 from the AAP. We're going to provide appropriate follow up based on the time of discharge and risk assessment. We're going to treat newborns with phototherapy or exchange transfusion as indicated. So if they have so much bilirubin in their blood, they may need an exchange transfusion, just meaning we're going to give them a bunch of blood, take out that blood that's got all that high bilirubin. We're going to give them blood that doesn't have it in, but usually the phototherapy works and we don't need to do that. Nurses' role in the prevention of hyperbiliry, what do I always say? Assessment, assessment, assessment. Evaluate the risk factors for jaundice. Do they have a risk factor? Is there an ABO incompatibility with the mom? Was mom Rh negative and now this baby's Rh positive? She had other babies that had high bilirubin levels. Facilitate early feeding and effective breastfeeding. It's going to be conjugated in the liver and that bilirubin is going to be excreted out the stool. They can't have stool if they don't eat, right? Education of parents and caregivers so they know how important this is. This is one, folks, that you can't take back. The baby will have brain damage if it crosses that blood-brain barrier and is for any length of time over 20. And evaluation of the pre-discharge bilirubin levels. There have been many a nurse fired because they sent a baby home with a high bili level. And you can't do it because we don't know. The parents don't know. We're held to a higher level because we know more. Risk factors of extreme hyperbiliry. Early onset jaundice, and here it is. I think we talked a little bit about it already. The Rh-ABO incompatibility, premature baby just because everything is immature, ineffective breastfeeding, they're not getting enough nutrients, bruising, cephalohematoma. What that is, it's not to do with nutrients and getting out of the stool. It's that we have a lot more blood in an area. And remember, a couple slides ago, we talked about how bilirubin is on the hemoglobin chain. So if we've got a lot of hemoglobin concentrated in one area, 10 to 1, we're going to have a lot of bilirubin in one area. Hemolytic disease deficiency, maternal age less than 25 years, who knows why. And Southeast Asian heritage, they just have a higher incidence. Lab eval, we always need to know what mom's blood type is and what Rh typing she is. Direct Coombs from cord blood when mother is blood type O and Rh negative, and we're going to talk about that. You probably already understand that. We're going to be talking about Coombs and direct Coombs in the complication lecture. And then the hemolytic disease risk evaluation and screening, which is the G6PD deficiency. It's another deficiency along the lines of galactosemia, which are inborn errors of metabolism. And here's our kernicterus, also known as acute bilirubin encephalopathy, because we know encephalopathy, it's just pathology in the brain. But this is a specific type of pathology in the brain. It's due to high bilirubin levels in the blood. Bilirubin is an excrement. It crosses that blood-brain barrier, and it just causes brain damage. Progressive signs, and these are signs of a kid that's got too much bilirubin in the blood, in the brain. Very sleepy, poor feeding, lethargic. They can have seizures. They come in, they have a very, very distinct, horrible cry. Decreased muscle tone, or even without tone. Hyper or hypotonia, arching, meaning their neck is arched back, markedly increased or decreased tone or bicycling movements, very, very high-pitched shrill cry, and they're inconsolable. Those are the ones that I've seen. Treatment. Phototherapy is a primary treatment for bilirubin. It reduces bilirubin levels very quickly and averts bilirubin toxicity. It doesn't treat the cause, though. We have to find out why. Is it ineffective breastfeeding? Was there a blood type missed where mom has sent antibodies over to the baby to break down their blood? We have to find out the reason. Phototherapy protocols vary depending on equipment. If they are in phototherapy, we have to check those eye patches frequently. They usually will take them off the baby once every 4 to 8 hours just to give the kid a rest. Record the irradiance of the bulbs in use, and the doctor will order exactly how much of the phototherapy they need what level it should be at. Monitor the temperature, skin integrity, intake and output, especially because we want that output. We want the baby's stooling to get rid of the excess bilirubin. And now they go home with the Billy blankets, where they actually don't have to have the patches. It's not overhead. They're laying on a blanket that can help them. So we're going to offer supplemental breast milk or formula as ordered. Supplement with water or dextrose does not lower bilirubin levels. We used to think it did. In jaundiced, healthy breastfed infants, they just want them to have the breast milk. Routine supplementation with dextrose water is not indicated. It's what we used to do to help with the stooling, and it didn't. They're just saying breast milk and more breast milk. And then again, the exchange transfusion is indicated for very severe hyperbilirubin when they can't get the levels down. It's when it's unresponsive to conventional treatment, which would be the Billy blankets, the Billy lights, and things like that. And what it does, it removes the bilirubin-laden blood, just takes it out because it's taking all their blood out, and it's slowly putting in plasma reconstituted packed red blood cells that have no bilirubin in it. And that's all I have. So I hope you enjoyed it, and I will see you in class. Take care.